In preparation for a luncheon seminar titled Why One-Piece HA-Based Implants Continue to be Supported, to be held at the 29th Academic Meeting of World Congress of Oral Implantology on July 13, 2025, I have decided to create a 15-minute lecture video. The lecturer, my name is Takao Kinebuchi, and I am a former president of the Japanese Society of Advanced Implant Medicine, an organization composed of HUB implant users. The evolution of implant treatment in Japan in recent years can be summarized as follows. From 1960 to around 1980, sub-periosteal implants, blade-bent implants, and bioceram implants were used, followed by the widespread adoption of titanium-based Bronnemark implants from the mid-1980s onward. However, during the same period in the 1980s in Japan, research and development of HA, hydroxyapatite, single-component implants, and HA-coated titanium implants were also actively pursued. As a result, many general practitioners, GPs in Japan, actively introduced HA-based implants into clinical practice alongside titanium-based two-piece systems derived from the Bronnemark system from the mid-1980s to around the year 2000. In ordinary plasma spraying, HA powder is instantly melted at 15,000 degrees Celsius in a plasma flame and bonded to the titanium surface. However, impurities such as calcium phosphate and calcium oxide are also simultaneously bonded. Additionally, the bonded state appears glass-like or honey-like, raising doubts about its functionality as HA. Development concept of one-piece HUB implant. The apatite-sintered implant APASRAM made by Asahi Kogaku Company Limited, released in 1983, was the first revolutionary implant that bone can biointegrate, but it had the problem of being brittle and easily broken. After that, early HA-based implants that were plasma-coated titanium were problematic because of their low purity. To solve this, Advanced Company Limited developed a technology to plasma spray beta TCP, a precursor of HA, onto pure titanium and then convert it into a high-purity recrystallized HA coating by hydrothermal treatment. In anticipation of the era of GPs rather than specialists in the near future, the one-piece, one-step method was chosen, and the surface is made of apatite. In the spirit of the simple is the best, the one-piece HUB implant was born in 1994 with the aim of simplifying the implantation technique and materials. A coating purity and evaluation. X-ray diffraction patterns show no impurities and recrystallized HA with high HA peaks indicating high purity. Scanning electron microscope images of the HA coating surface reveal a surface densely covered with apatite crystal structures. The titanium system requires a high surgical precision, but if the surgical precision is not high, fibrous connective tissue will intervene and cause areas where bone union does not occur, as shown in the pathological image. While the HA system has osteoconductive ability and can lead to bone union on the entire surface with new cancerous bone, as shown in the pathological image, without requiring a high surgical precision. While it takes a long time for the pull-out test value to increase with titanium, the test value to withstand occlusal force is reached in 2 to 3 months with HA. This is an excerpt from the Journal of Biointegration, Volume 1, Number 1, 2011, by Hideki Aoki et al., illustrating the development history of HA-based implants in Japan. The lecturer, after using upper serum as shown in the previous slide, joined Advance Company Limited in 1985 for the development of a HA-based one-piece implant, underwent clinical trials, received approval from the Ministry of Health, Labor and Welfare in 1993, and the implant was launched as the AQB implant in 1994. The history of development of AQB implant is as follows. The clinical trial from 1988 at Mitsui Memorial Hospital and from 1990 at the Nippon Dental University applied for and was approved by the Ministry of Health and Welfare in 1992 and was put on the market in 1994. After its launch, trial sessions were held all over Japan. The number of users increased, and it is well known that it has grown to become the major HA-based implant used in Japan. The annual IAI research meeting by AQB users, which has been held every year since 1998, became the Japanese Society of Advanced Implant Medicine (AIM) in 2008 and has been active as a general incorporated association since 2011. The product forms of AQB implants have diameters of 3 mm, 4 mm, and 5 mm. The ratio of the length of the root portion covered with HA that enters the bone to the length of the abutment portion exposed in the oral cavity, which is mirror polished, resulted in 21 product types at the time of launch, which soon increased to 27 types. As a result, in 2013, the number of sizes of both straight and T-type in the one-piece category has increased to 33 varieties. Also for two-piece, there are 12 types. Incidentally, I am a one-piece person exclusively. The 2017 product list has the same types but at slightly lower prices. Dental implant treatment in Japan has seen the coexistence of titanium-based two-piece implants and HA-based implants over the past quarter century. One-piece HUB implant, which I have used for 34 years, was widely adopted across Japan, particularly among general practitioners upon its release in 1994, and became the flagship product of HA-based implants, dominating the market for a time. However, in Japanese dental universities, titanium-based two-piece implants became the mainstream standard, and since 2010, they have been regarded as the standard for implant treatment. Implant education for students at universities focused solely on the titanium-based two-piece systems, resulting in young dentists entering the field knowing only this system. On the other hand, users of HA-based implants are gradually aging. HA and the frequency of their use is showing a declining trend, promoting concern among enthusiasts of HA-based implants. Data on the market share of dental implants sold in Japan is not readily available, but I found a chart showing the market share in 2020 edition of Quintessence Dental Implantology, Volume 27. The chart represents the average market share over the 3-year period from 2015 to 2017. Imports account for 3/4, domestic production for 1/4, and roughly 80% appear to be titanium-based, with approximately 20% being HA-based. If we strictly classify HA-coated materials as HA-based and exclude those whose titanium surface roughening achieved through acid etching after HA blasting, domestic HA-based materials include AQB, POI, now financier, mu1, and Platon's bio-based materials, while imported materials include the MP1 HA coating from Zimmer Biomet, formerly Hakuho. Advantages and disadvantages of both implant systems. HA-based one-piece and titanium-based two-piece systems each have their own advantages and disadvantages. By gaining experience in treatment that thoroughly understands and addresses the disadvantages of each system to prevent issues, I believe that there is essentially no difference between HA-based and titanium-based systems. The major difference between these two treatment methods is that the titanium-based system has a more complex treatment process and higher treatment costs. On the other hand, the HA-based one-piece system features a simple treatment process and can be implemented at treatment costs that are less than half of those for the titanium-based two-piece systems. Specifically, the features and advantages of one-piece AQB implant as perceived by the speaker are listed below. I will now explain each point from number 1 to number 9 in order using case examples. Features and advantages. Number 1. Both the form and procedure are simple and similar to the natural teeth. The AQB to be implanted at upper anterior region tends to be protrusive. Therefore, by implanting in the most favorable direction and after suturing, the tooth axis is corrected to the parietal direction by forming the abutment tooth outline from the labial side. A region temporary crown tech can be applied to the same day or the next day. Biointegration is achieved on average in 2 months, allowing final finishing, impression taking, and fabrication of the final crown around 2.5 months, similar to the natural tooth restoration procedures. Features and advantage. Number 2. HA-based give early biointegration and high occlusal support. In this case, implants were placed in the lower right 765 defects and restored with single crowns. This is the case after 6 months implantation, but the surgical invasion of implant socket formation temporarily left a mild slit-like bone form at the alveolar bone surface. This is 11 years after implantation, and vertical bone augmentation occasionally observed in mandibular molar area in HA-based implant. Features and advantages. Number 3. 7 mm of space to mandibular canal is enough for 6 mm product. This case is bilateral molar defects and the mandible, and both sides were implanted in sequence. The left side 6 area was 5SS, but the right side 6 area was number 568, because overly conscious of avoiding the risk of nerve damage, I implanted number 568, the model number with the shortest fixture, even though 5SS would have been possible originally. In the long term, I feared that the patient would suffer from occlusal trauma and have a short life. The patient's oral cavity and radiographs after 10 years were taken. As mentioned in number 2 feature, there is clear vertebral bone augmentation has occurred at the alveolar apex. In the case of biointegration, it is thought that the organism has created the necessary bone structure to support implant occlusion. Thus, even in cases where the distance to the mandibular canal is short, short 5S or 4S implants were used almost successfully. Features and advantages number 4. 3 mm product could be used for narrow bone widths. This case was implanted in a mandibular bilateral molar defect. The bone width of the right side crest seems to be adequate, but the left side is narrower, and two bicuspids were implanted with 3M, and first molar with 4M, and three connective crowns were planned. This upper intraoral bilateral view at the first visit. This is a patient who meticulously went for annual implant checkups, even after the implantation prosthetics. Lower left 4, 5, 6 area, 18 years after implantation, and lower left 7 treated by patient's request, 14 years, 7 months after. The patient is followed up every year, but even with 3 mm diameter molars, the patient is still safe as 18 years with connected crowns. Features and advantages number 5. Subgingival preparation is similar to natural teeth that guarantee aesthetics. This case is a patient who had 4 anterior maxillary teeth. The upper right tooth was extracted because it could not be saved. Later AQB was implanted at upper right tooth area. This is the impression of the 4 anterior teeth, and 4 single porcelain fused metal crowns were replaced at the patient's request. The following are the intraoral and dental radiographs taken at the 21st year of the patient's regular annual checkups. As you can see, aesthetics are well secured even with a one-piece implant. Features and advantages number 6. Can gradually transition to a cubic crown bridge while using partial denture. In partial denture up to moderate defects, it is simple to cut out the denture base and the necessary area desired by the patient and replace the same area with a cubic crown bridge. Let's summarize the method of transition to AQB for multiple tooth defects or edentulous cases. There are various cases depending on the condition of the jawbone and the patient's wishes, but I will try to categorize the cases of one-piece AQB implant treatment for the edentulous mandible. The simplest and most effective is bracket 1, bilateral 3-3 area implantations with a single crown plus partial denture. This prevents the denture from moving, which is good news for the patient. Next is bracket 2, bridge plus partial denture with bilateral 3-4 area implantations. Bracket 3, bridges with 3 implantations bilaterally so that the denture can be placed only on the molars. Bracket 4. If the patient wishes to have implants in all possible areas, then implantation in 5, 6, 7 areas bilaterally, and restoration with crown or bridge will completely eliminate the need for partial denture. We will now review the procedure and the example treatment of bracket 4. First, cut off the floor of the lower right for 3 and 2 areas and implant it there. Then attach the for 3 connected temporary crown and the 2 single temporary crown on them. After bone union, connected porcelain fused metal crown fabricated and for 3 areas and leave the 2 areas as still temporary crown. Repeat the same things you did for the 2, 3, 4 areas at the lower right of it in turn for the other part of the body. Next, bridge is fabricated on the lower left 5 and 7 and the lower right 5 and 7 parts to be implanted and bridge. The mandible is completed. The same procedure is used for the maxillary with 4, 3, 2 area on the upper right and the upper left 2, 3, 4 areas, bridges into 2 parts bilaterally. Upper left was implanted in 5, 6 area and single crown. Finally, upper right in 6, 5 area and single crown. This allows us to replace the entire jaw with implants. The process of implanting the AQB, bonding the bone and inserting the crown, hanging the clasp to maintain the denture, and then moving on the next implantation area was repeated to gradually replace the multiple crown bridge of AQB. The implant prosthesis was completed after 2 years, 11 months. This overview is about 4 years after the completion of the treatment. Features and advantages number 7. No requirement for autogenous bone graft nor bone substitute during socket lift. The patient is a 41 female with a left upper 5, 6, 7 defect with a lowered maxillary sinus floor and extremely thin bone to the floor of the sinus. First, at upper left 5 areas, it was possible to implant without breaking the mucosa of the sinus floor, and the oozing elevated the mucosa of the sinus floor in a dome shape. When the bone in the same area about the floor of the sinus had matured, a resin crown was placed over it, and the same socket lift was performed in upper left 7 area. Fortunately, initial fixation was obtained in 7 area, and bone union was achieved smoothly. After the 7 area was integrated, resin bridge was placed, and weak occlusal force was applied to weight the bone density to increase. After 3 months of use of the resin bridge, a final impression of the bridge was made, and the final bridge was placed. As you can see in the dental radiographs, excellent bone has grown above the elevation of the floor of the sinus without bone substitute, and cortical bone has formed in the new floor of the sinus. The patient's subsequent progress was also favorable, and dental radiographs after 8.5 years shows that the organism has undergone a remodeling process to the minimal bone form required for occlusal support. Features and advantage number 8 can be used simultaneously with orthodontic treatment. A case of orthodontic treatment for maxillary prognatism with implants with an anchor. The patient was a 55 years old female. First visit 2004. At first, when at the orthodontist's office, refused orthodontic treatment because of many molar defects. She had a bite that was close to skeletal maxillary prognathism, with the mandibular arch almost completely inserted into the maxillary arch. Upper and lower premolars misaligned, lower bilateral incisors were congenitally absent, and multiple missing molars in the upper jaw. Nevertheless, she wanted orthodontic treatment. AQB in upper right 6-5 and upper left 5 area as anchors could perform orthodontic treatment with an efficiency unthinkable in natural tooth anchor, and with near supernormal stability due to the pressure drop of upper right 4-3 area and the contraction of the maxillary arch. The patient's occlusion is now stable and the AQB has been stabilized. The oral cavity and radiographs are 8 years 4 months after the completion of orthodontic treatment, and the AQB is still stable. Features and advantages. Number 9. Can provide low-cost implant treatment. The price list for one-piece implant is 33,600 yen per implant as at 2020 for all model numbers, and no other fees are charged. Therefore, it is possible to set up a low-cost implant treatment system. On the other hand, the two-piece type is 36,000 yen per fixture plus the cost from 27,000 yen to 32,000 yen per abutment. Various other equipment is also needed when taking impressions. In addition, many tools for two-piece implants need to be purchased additionally, and the laboratory technical fees of two-piece implants is considerably higher than that of one-piece implants. Therefore, it requires expensive implant treatment system. I hope you now understand the characteristics and advantages of the 9 items of the one-piece AQB. Now you have understood the importance of periodic checkups by maintenances for implant treatment. I will explain the points to be observed during periodic checkups in 4 categories. First, understanding the unique response of HA implants to occlusal trauma. The second, identifying patients with strong occlusal forces who are prone to occlusal trauma. The third, awareness that occlusal position usually changes slightly over time, especially in patients with chronic temporomandibular joint disorder. Finally, as a fourth, monitoring for infection from chronic periodontitis of adjacent teeth or root apex regions due to the rough surface of HA. I will briefly explain each of these 4 points and would like to remind the importance of periodic general dental checkups. The first section of the observations during periodic checkups. Understanding the unique response of HA-based implants to occlusal trauma. The speaker has been managing the occlusal adjustment of AQB implants for many years and has found that HA implants are living organisms. When the bone is in a state of hyperpermeability, this is a change in the superficial bone around the implant, which is a preliminary stage of slit or mortar-like bone resorption caused by occlusal trauma, and the bone in the same area will show increased radiographic permeability. However, we have experienced many cases where healthy bone structures have regenerated in the hyperpermeability area by reading the signs on dental radiographs taken during periodic checkups and removing the overload by making appropriate occlusal adjustments. Here is one such case, a 73-year-old female patient who had been doing well for 3 years after implantation, presented for a routine implant examination in the 4th year. At that time, a slight slit-like area of increased radiolucency was observed on the right upper sixth tooth in the mesial direction. This was considered to be due to overload, and the buccal occlusal surface was adjusted by grinding. 1 year later, the mesial slit-like radiolucency had progressed to the first thread level, and the distal region exhibited diffuse radiolucency extending to the second thread level in subperiosteal packet-like pattern. I determined that the overload had not yet been resolved by the occlusal adjustment of 1 year ago, and performed further occlusal adjustment. 1 year later, radiolucency region observed in the previous year had resolved with occlusal adjustment to relieve the overload, and clear bone regeneration was evident. Really, HA-based implants are living organisms. I will ask you to look at another case in which the patient was able to biointegrate after dislocation due to overload. The case is a 63 years female with relatively remaining teeth, although maxilla had many upset teeth. Because the second molar area has a low bone height diameter to the floor of the sinus, I planned to implant in the bilateral first molars, which could be implanted relatively safely by socket lift. The slide on the left shows the upper sixth tooth at the 1 year follow-up examination with no significant issues. However, at 10 months later, the patient presented as an emergency due to mobility in the upper sixth tooth. Dental X-ray revealed what appeared to be resorption around the implant, consistent with dislocation. I decided to remove the crown without causing further damage and monitor the situation, hoping for biointegration. The 10 remaining natural teeth in the maxilla were found to be mobile due to being pushed upward by opposing teeth during occlusion, indicating that they had primarily relied on implants on occlusal support until now. The sprint made by the referred dental clinics were reported rarely used. After 2 months from crown removal, mobility decreased and bone regeneration around the implant was confirmed on dental X-rays. At 4 months post-crown removal, biointegration was achieved, so a raising crown was temporarily cemented to allow for further bone integration. The implant was ultimately refabricated with a gold alloy crown after 9 months of dislocation. The lower right slide shows the intraoral view 6 months after reattached crown, showing even white paper marks on both the implant and natural teeth, indicating that the natural teeth and the implant are sharing the occlusal support properly. I will say it again, HA-based implants are living organisms. Next, the second section of the observations during periodic checkups, identifying patients with strong occlusal forces prone to occlusal trauma. Unlike patients who lose natural teeth due to chronic periodontitis, there are patients who have strong biting forces and tend to lose teeth due to traumatic factors such as crown fractures and root fractures. In such patients, the implants are gradually exposed to occlusal trauma due to abnormal occlusal wear and swaying of the remaining teeth, causing slit or mortar-shaped bone resorption, dislocation of the implant body, and increased risk of implant fracture. So periodic occlusal adjustment management is extremely important for implant maintenance. Then I will try to summarize the methods of prevention and remedies for occlusal trauma. This is a panoramic radiograph of a patient who was seen by another dentist for implant request. The left and right sides of the radiograph are indicated. The bilateral mandibular angles are huge, showing the aspect of so-called gorilla jaw. In addition to the upper right 4 that was extracted due to root fracture, the proximal root of the lower right 6 and the distal root of the lower left 7 were also fractured. The lower left 7, despite being a living tooth, and a large apical root region was formed in the upper left 5 despite a firm root canal treatment, suggesting the involvement of occlusal trauma. Patients with stout mandibular angles should be noted. As a theory based on experience, there is a close relationship between function and form. Patients with stout mandibular angles naturally have well-developed masseter and temporomandibular muscles, and their occlusal force should be strong. In addition, I believe that alveolar is often seen on the buccal side of the teeth, and mandibular torus is often seen on the lingual side of the mandibular body. Even when chewing the same food, the masticatory force, bite force, varies greatly from person to person. Patients with stout mandibular angle prefer hard foods such as hard crackers, hard French breads, and hard nuts, which may easily cause occlusal trauma. They also seem to be more prone to occlusal trauma, namely, teeth with advanced occlusal wear and tear for their age, crown or root fractures, or pulp-treated teeth that initially showed good progress are more likely to develop root apex regions over time. Instead of causing damage to the teeth, the temporomandibular joint may be damaged, resulting in symptoms of so-called TMJ disorder. It is important to identify potential candidates for occlusal trauma in advance and establish treatment plans or schedule regular checkups based on these various factors. Next, let's look at the third section of the observations during periodic checkups, which states that the occlusal position changes slightly over time. Enter. It is well known that occlusal trauma is often seen in the last molars, but we think it is important to be aware of The observation that occlusal conditions, not only implants, change slightly over time. Bite is a phenomenon in which the teeth of the upper and lower jaw function by contraction of the masticatory muscles with the temporomandibular joint as the fulcrum. The cartilage of the temporomandibular joint atrophies over time as a result of aging, and because there are differences between the left and the right sides of the joint, abnormal changes in occlusion can occur over time. It is necessary to read the occlusal changes during regular checkups and make appropriate occlusal adjustments to achieve a balanced occlusion of the whole jaw. Some patients with a strong bite who prefer to eat hard foods or who have a long-standing tendency to TMJ disorders sometimes come to the clinic with a sudden unilateral opening-like condition due to deformity, resorption, or deviation of articular cartilage or articular disc. In other words, only the last molar on the affected side is in occlusal contact and the contralateral side is open. In such a case, we use anti-inflammatory and analgesic drugs during the initial inflammatory phase and symptomatic treatment to adjust the occlusal significantly to achieve occlusal contact of multiple teeth on the left and the right sides as much as possible. The patient should then avoid the intake of hard foods and use aspirin to prevent recurrence once the occlusal condition had stabilized. Early occlusal adjustments may prevent deterioration of such TMJ-related occlusal changes, and it is important to check these changes during regular checkups. We sometimes see cases of long-term chronic TMJ disorder patients who suddenly develop unilateral open bite. The patient is a 66-year-old female who came to our clinic in 2021 April on the recommendation of one of our patients. She had TMJ disorder for a long time and had visited various medical institutions, including a university hospital. When she came to our clinic, she had occlusal contact only with the upper left 7 and lower left 7, and no occlusal contact with the other teeth. The patient had been in this occlusal condition for more than a year, probably due to resorption of the cartilage of the left TMJ, and had only received splints at all medical institutions. At the initial visit, the crown of the lower left 7 was removed and the grinding and adjustment of multiple teeth was performed. This slide shows the occlusal state 4 weeks later with stable occlusion in all jaws. To prevent recurrence, an impression of the anti-clenching splint was taken on this day. This case is not an example of an implant patient, but we have experienced many cases of similar sudden unilateral open bite in implant patients with chronic temporomandibular disorder. And if the early contact tooth of the last molar is an implant, the implant will have problems due to occlusal trauma if significant grinding adjustments are not made in a short period of time. Finally, we come to the fourth section of the observations during periodic checkups, monitoring from chronic periodontitis of adjacent teeth or root apex regions. It is not infrequent that infection spills over from chronic periodontitis, apical periodontitis, residual roots, residual cysts etc. in adjacent natural teeth while waiting for a visit. A periodontitis develops. In this case, the disadvantage of HA implants compared to titanium implants is that HA implants have a rougher surface, so they are more likely to pick up infection from adjacent natural teeth and expand along the HA surface in a short period of time. For its prevention, regular checkups of the trinity of periodontitis, caries, and peri-implantitis in daily clinical practice are irreplaceable. Patients should be educated about how the deterioration of the condition of adjacent natural teeth can have a decisive negative impact on implants, and motivation for regular checkups should be encouraged. Diagnosis of treatment of peri-implant bone. If there are signs of increased radiographic permeability from the superficial layers or mildly mortar-shaped vertical bone resorption, radiographic checkup 3 to 4 months after crown placement will reveal the signs, and further bone resorption can be prevented through occlusal adjustments. For patients with clenching habits, nighttime sprinting can be used to prevent further bone resorption. Peri-implantitis due to peri-implant mucositis caused by poor oral hygiene or moderate slit or mortar-like bone resorption caused by occlusal trauma can be prevented by improving the level of tooth brushing during regular checkups, detecting bone resorption in its earliest stage, namely before it reaches the threads, and performing flap operation. If the subgingival pocket is brought back to the normal range by bone form correction, it is often possible to control the inflammation without recurrence thereafter. Current status of HA-based implants. As the user base ages, the market share of HA-based implants in Japan has been gradually declining. However, users who have come to appreciate the advantages of HA-based one-piece implants tend to remain loyal to them, continuing to use them without switching to titanium-based two-piece implants. As an advisor for HQB ABI Implant Company Limited, I am involved in sales strategies, and starting in early 2024, we'll work on expanding overseas sales channels. This includes creating a one-page A4 brochure summarizing the clinical use of HA-based one-piece HB implants, as well as a 82 minutes promotional video for an introductory seminar, which I have uploaded to YouTube to make them accessible to many dental practitioners. HA-based one-piece HB implant A4 sized lecture paper. This is a brochure that condenses the overview of the HA-based one-piece HB implant system onto both sides of a single A4 paper. The introductory promotional video uploaded to the public website at YouTube is now available, revised to the 2025 June detailed version. The description below the cover image reads, "This introductory lecture is an 82 minutes presentation by a practitioner who has been using HA-coated one-piece HUB implant for approximately 34 years since the mid-1980s, explaining all the advantages of HA-coated one-piece implants." Why does HA-based one-piece implant continue to be supported? Summary of this lecture. The answer to this question can be summarized in the 9 items in Part 3, Features and Advantages of One-Piece AQB. Furthermore, as mentioned in observation points during regular checkups for HA-based implants, appropriate occlusal adjustments in response to signs of occlusal trauma can lead to bone regeneration, reaching the point where one realizes that HA-based implants are living organisms. Additionally, by detecting peri-implantitis early during regular checkups and addressing it through occlusal adjustments or flap operation, it is possible to maintain the current condition, or in some cases, bone regeneration is possible. This experience has led many users to become loyal to HA-based one-piece implants, which is why HA-based one-piece implant has been supported for so long time. Concluding remarks. Due to time constraints today, I was only able to present a limited number of clinical cases. However, by reviewing the long-term outcomes of 10 years or 20 years, you will understand that once the management techniques for HA systems are mastered, they are comparable to titanium systems. I have set up a system where previous lecture content can be viewed via my Dropbox sharing folder on the website, as shown in the next slide URL. For more details, please refer to the link provided. I believe this will help you better understand the advantages of the HA systems. Thank you for joining today's luncheon seminar.